pretty much all or mostly here, so why don't we get started? We may have another couple of folks joining us coming from other meetings, but I think we have a critical mass here. So Mayor Manheimer, I understand, is out of town today, so she won't be with us, but of course we have Vice Mayor Gwen Whistler with us and other members of the City Council and the Commission. So I just want to say thanks to everyone for getting together. This is kind of the, we've had a couple of other previous sit-downs with our colleagues from Mission and folks who are working on the formation of the Dogwood Trust. And so this is kind of just, I think, another opportunity for us to get an update, ask questions, and have a good dialogue. So I just want to say thank you to everyone for being with us. But I think probably most everyone knows, probably most everyone here, but it's a pretty small group. So why don't we just go around and just everyone introduce yourself, and then we'll turn it over to you guys to kind of give us some updates on things happening, and I'm sure we'll have a good discussion. So thanks for being here. I'll start off. I'm Brownie Newman. I'm the chair of the County Commission. We'll start this way, and then we'll get the outside people too.
Bring it. Vijay Kapoor, Asheville City Council.
Brian Haynes, Asheville City Council.
Shanika Smith, Asheville City Council.
Gwen Whistler, Asheville City Council.
Terry Van Dyne, North Carolina Senate.
Not Asheville City Council. Julie Mayfield, Asheville City.
Rowena Timms, Government and Community Relations for Mission Health.
John Ball, Chair of the Mission Board.
And Janice Brummett, Chair of the Dogwood Health Trust Board.
Kathy Ball, Interim City Manager.
George Wood, Interim County Manager.
Ellen Frost, Buncombe County Commissioner.
Al Whitesides, Buncombe County Commissioner.
Joe Belcher, Buncombe County Commissioner.
All right, and let's go on the outside too.
Frank Caboni, News 13.
Thanks for being here.
Keith Miller, County Tax Assessor.
Dan.
Dan, County Communications.
Cameraman, we gotta hear from you too.
Bill Evans, WLOS.
All right.
Stony Glenn's on the Buncombe County Health and Human Services Director.
I'm Jim Holland, Assistant County Manager.
Mark Barrett, Asheville Citizen Times.
All right, thank you all.
Oh,
whoops, sorry.
Lamar Jordan, Clerk to the Board of Commissioners.
All right, thanks, Lamar. Good to see you back there. All right, thank you all for being here, and turn it over to you guys.
Thank you, Brian.
Yeah.
As I said, I am John Ball. I'm Chair of the Mission Health Systems Board of Directors, and with me is my colleague, Janice Brummett, who, as she said, is Chair of the Dogwood Health Trust Board of Directors. We're very pleased to take this opportunity to brief you on the status of both the transaction with HCA Healthcare, as well as the status of the Dogwood Health Trust. We really appreciate your interest. Each of us has about a 5-minute brief statement at the start, and then that'll give plenty of time for questions, and we hope to have a conversation with you guys. So thank you very much. First, a little background. The mission of Mission Health is to improve the health of the people of Western North Carolina. It's that mission that the Mission Health Board is the steward of, and it's that mission that has consistently guided our deliberations. How best to meet the mission has been the subject of several strategic planning retreats over the last few years of the Mission Board. Until recently, our default position was to remain independent. Why? Because we've done very well independently. Mission, as you know, has been named by IBM Watson Trugan Analytics a top 15 health system 6 of the last 7 years. No other hospital, no other health system in North Carolina has achieved that designation. No other system or hospital in the United States has achieved that record of 6 of the last 7 years. And that ranking is not based on opinion, it's based on hard data with regard to quality and efficiency. And while maintaining and improving quality, we've consistently cut costs. Compared with a peer group of North Carolina hospitals chosen by the state, our cost per case is about $1,000 less. Over the past 5 years, we've taken $240 million out of the annual cost fund, and in the most recent fiscal year, concluded September 30th, we took $70 million out. There's another reason to remain independent. No potential partner could offer an advantage to us in increasing revenues, decreasing cost, or improving quality. Until such an advantage could be shown, we would remain independent. That was the assumption of the board. But Western North Carolina has a demographic problem. Our citizens are older, sicker, poorer, and less insured than those of the rest of the state or of the nation. In addition, our region is not only the epicenter of opioid crisis, but behavioral health issues threaten to overcome our community resources. Mission's emergency department is the busiest in the Carolinas, and many of those patients are behavioral health issues. In addition, Western North Carolina has a health economics problem. 72% of our patients are covered by Medicare, Medicaid, or are self-insured. That means that we lose money on 3/4 of our patients. In addition, nearly 3/4 of the remaining patients are covered by the dominant insurer in the state, and the outcome of our negotiations last year demonstrated that they were unwilling to raise rates to meet inflation even on their own members. So the board was faced with a difficult choice: remain independent and continue to cut expenses every year by 50 to 70 million just to break even, or find a suitable partner. Our analysis was that remaining independent was not a long-term viable option because it would mean very shortly cutting clinical programs and clinical services. All the low-hanging fruit, indeed all the fruit, had already been cut. And it would mean no new behavioral health hospital, no replacement hospital in Franklin, and a potential closure of some of the critical access hospitals in the region. The value of the transaction with HCA Healthcare can't be measured against what Mission is now, but what Mission would have had to have been in 5 to 10 years. So the board set out to find a suitable partner, and after considering several, settled on HCA Healthcare unanimously. Unanimously not only in the vote of the Mission Health System Board, but also ultimately in the votes of every single regional hospital board. What HCA brought to the table was the ability to maintain healthcare in the region with the kind of commitment to quality, accessibility, and affordability that the people of this region have come to expect from Mission. The economy is not in clinical areas, but in the back office functions. In addition, in our negotiations, they agreed to maintain services and facilities for substantial periods of time at all of our hospitals, a guarantee far better than Mission alone could ever have made. They also guaranteed a level of charity care equal to or better than the largest health system in the state. Further, as part of the transaction, the Mission relationship with Mayhat will not only be preserved, but be enhanced. So, health care preserved to the extent possible, health care preserved to the extent possible, and the Conversion Foundation, Dogwood Health Trust, the largest foundation per capita in the country, which is projected to spend roughly $75 million annually in Western North Carolina on what we term the social determinants of health. Health status of individuals is determined by a variety of factors, and health care is only responsible for about 15 to 20%. Other factors, and Janice will mention these in more detail, are more important. Health care helps people get well when they're ill. What Dogwood Health Trust will try to do is to help people be well and stay well. Finally, as part of the transaction, Mission and HCA will each contribute $25 million to an innovation center to help small businesses in the region. Mission has already committed $15 million each to each of the 6 legacy foundations, including the Care Partners Foundation. And finally, there's an item of importance to the city and county governments. HCA will pay property and sales taxes estimated to be from $15 million to $25 million on an annual basis. The status of the transaction today is that of an asset purchase agreement among Mission and its affiliated organizations on the one hand and HCA on the other. The agreement was transmitted to the Attorney General on September 1st. The Attorney General by statute has 30 days to perform the review and can request another 30 days. But there is a catch. The 30-day period begins only when the AG determines that they have all the relevant information to review. And while we've been working with the AG's office since early summer, they have yet to say that the review period has started. This transaction is tremendously important to the people of Western North Carolina. It's also tremendously important to the ability of Mission's caregivers to perform at the level expected of them. The stress of an uncertainty, the cost of delay is immeasurable. We have to be patient, and we ask for your patience. Thank you.
And again, my name is Janice Brummett, and I am the inaugural chair of the Dogwood Health Trust Foundation and Dogwood Health Trust. And I want to tell you a little bit about the formation and what we're doing currently. A lot of the information has been shared by John, but I want to elaborate a little bit. The Dogwood Health Trust is the fiduciary organization which will receive, upon completion of review by the AG and the close of the transaction between HCA and Mission Health, the sale proceeds from the transaction. First and foremost, the money received will serve to dramatically improve the health and well-being of the people and the communities of Western North Carolina. There has been significant interest surrounding the foundation, and I hope to provide you additional information today. So, as I said earlier, the trust has several fiduciary responsibilities. Let me explain how it was formed and what the charge will be. The asset purchase agreement calls for HCA to give Mission Health $1.5 billion for the sale. Our hope that the trust will receive this money in early 2019 based upon the closure of the agreement. This amount of money will be a game changer for Western North Carolina. The corpus of the trust will spin off, as John said, $50 to $75 million per year, starting in 2020. So we'll get the money in 2019, and in 2020 we will prepare to give grants and assistance. These dollars will be focused on individual community needs throughout the region, because we recognize that each community and its citizenry is different than every other community in Western North Carolina. And the focus will be on social determinants of health, meaning the things that are known drivers of health and well-being. That's not healthcare per se, but that's what happens to you before you need to have healthcare. The trust will be a non-operating foundation, which means that it will not be operating the programs, but it will be partnering with nonprofits, government agencies, and others to solve the issues in the region. The trust has and will continue to engage national and statewide experts to assess the strengths and opportunities in our communities. If you attended the event on September 30th, you got to hear one of our national experts on social determinants of health. Her name is Rebecca Oney. And we will be engaging her team and other experts going forward to help us to create our grant and our evaluation criteria going forward. Another immense responsibility of the trust will be the enforcement of the guarantee that HCA makes in the asset purchase agreement. This is no small responsibility. HCA will agree to maintaining services in the rural hospitals and on the main campus going forward for a period of time. They will agree to build a behavioral health facility in Buncombe County and a replacement hospital in Franklin. They also agree to maintain a charity policy that is equal or greater to the biggest nonprofit health system in the state. All of these guarantees and others that they will make in the asset purchase agreement will be monitored by the trust. These are protections for the health care of our citizens for 10 years and beyond. And we have been asked how the Dogwood Health Trust board members were selected. Let me give you some background on that. First and foremost, the Mission Health System Board has the ultimate legal responsibility to oversee both the delivery of health care and the delivery of resources from the sale. The Mission Board approved the first 6 board members and the remaining 3 board members that we named a little later. There are certain criteria that appear on the Dogwood Trust website that you can see where we chose the board members, and we chose them because of several factors. One is their knowledge and of healthcare delivery, their civic engagement, their regional representation, and passion for the citizens of Western North Carolina. The Trust plans to name 2 additional members by the end of 2018. We are seeking to enhance the board's regional, gender, and racial diversity. So, what are our next steps? As you can imagine, because it's in early formation stages, we have a laundry list of tasks to do, much of which is neither sexy nor exciting. But what is exciting is that we will be going out into the region in the next 2 to 3 months, and we will be engaging nonprofits, elected leaders, and others, and actively listening to what they think they need in their communities. We will be developing a staffing plan and CEO criteria, and we hope to name our other 2 additional board members of the year. So that gives you a little update on what we're up to. As you can tell, we have a lot of things on our plate, but we're trying to tick those off very rapidly to the best benefit for the region. So we would be happy to answer any questions that you have.
Yes, Chair. Senator.
I just wanted to make a comment. I did have a brief meeting yesterday with Jennifer Herod, and what you say is true, that they believe that they are still waiting on some data. The Attorney General's office, I'm sorry, Jennifer Herod is with the Attorney General's office, but they are very much aware of the fact that there is pressure to get this done by the end of the year. I think it is fair to say that they want to meet that deadline. However, I think it's also fair to say that they take their responsibility to do due diligence very seriously as well. So I just wanted to elaborate on your characterization of.
Well, I've had the pleasure of reading all the correspondence between and among the attorneys. It is voluminous. Some of the questions get asked over again, and we put further information in. The real cost of this is the cost of the people at Mission and at the hospitals at the local level. Uncertainty breeds uncertainty, and we're unable to recruit physicians. The entire leadership of the revenue cycle team, that's the people who help bill and bring in the money, have left because they figured that their jobs were going to be gone, even though we put the retention incentives in their contracts and the like. So there's real stress on both the caregivers and the rest of the team at this stage of the game. The monetary cost is about $20 million per month. Every month it's delayed. Most of that money is for the new tower. Part of that money is for interest. So both the human cost and the ability to continue to deliver care at the quality level is what's threatened if we're delayed beyond the end of the year.
Right, and I appreciate that. I just was expressing the fact that they acknowledged the fact that that was a deadline that they were trying to work to. I think it's important to realize, though, that you all have been working on this for, what, over a year? And the rest of the community has to catch up. And that it has to take whatever time it has to take.
I'm sorry, I had 2 questions. Hopefully they'll be pretty brief. One is, and I appreciate this. I've actually had the opportunity to meet with Dr. Paulus Molina. I sent out some questions I had about that. First off, I want to thank you all for being very responsive. So the questions I'm going to ask here were questions that I asked with you all as well, but I think they're important for kind of folks to hear generally. So one of the things that's built into this, as you talked about, Dr. Ball, was some protections as to services for a 5-year period. In the Asheville area, essentially saying that the HCA will continue these, for a period of 5 years.
In the Asheville area, for Mission and for Care Partners, it's 10 years.
10 years, excuse me, I'm sorry, 10 years.
Services for 10 years, and then there are various further guarantees in the out years as well. There have to be criteria to do anything to change further services after that.
And thank you for correcting me. In that, there is, even after this, or even within those 10-year periods, there is some language in there that says if they are not, I forget the terms specifically, but there was some type of language in there that could potentially have those eliminated within that 10-year period. But there was a process in there that had some type of board. Can you, if you recall, can you talk a little bit about that process? There's some
The two basic criteria that something could change within the 10-year period is the legal term force majeure, which basically means such an event that it would be impossible to continue. Hurricane, for example, destroys the place. The second criterion is if the services became unable to be supported in a financial kind of way. But part of those criteria are that meant that 33% of the services dropped. So that was one of the criteria. And then there's several others with regard to volume, financings, and the like. And then there's the input that the advisory board, which is half HCA and half people appointed originally by mission, would have to agree upon on a majority vote of both parts. So 4 people from mission, 4 people from HCA, 3 people from each would have to agree to make change.
Right. So my point here was that there's a pretty stringent process within that as well. The second question I had, this was more general. You know, we appreciate the fact that this is the second time you all have come out here to talk to us about it. You know, there's a lot of questions that folks have, you know, in the community about HCA, right? You know, you all are giving us kind of the perspective from mission's end, and you all have been spending a lot of time doing it. You know, one of the things I think would be helpful, and we've requested this before, understanding, is the opportunity perhaps for HCA to be able, at some point, to meet either with us or with others as a, you know, as a way of kind of essentially reinforcing a lot of what you all are telling us here, since, you know, theoretically, once the deal gets done, you know, they're essentially going to be the ones calling the shots. So I'll reiterate that request if that's possible.
And we've talked with them about that. We will talk with them again about that. The interesting piece is the HCA business plan in the past has been the buying of distraught hospitals, distressed hospitals. And when we talked with them about how did the community accept, you know, when you came in before, they said the community has loved us. We've never had a situation where the community is a little bit strange about it. So I think they've taken some education, and I think they would be happy to have the dialogue. I know they're talking about having a dialogue out in the regional hospital area as well.
We're working to that end. It'll mid to late November.
Okay, great, thank you.
I've got just a couple questions around jobs and sustainability of jobs related to the hospital here in this community. So the first one is around wages. Do you all know, and this again might be better put to HCA, but they're not here, so I'll ask you. Do you know if they're, you know, for wages for people like techs and nurses and folks, you know, who maybe some who are on the lower end of the pay scale, is there, do you know what HCA's plans are for those wages? Are those folks can either continue to make a wage that will allow them to live here, or any plans for change?
2 or 3 different kinds of answers to that. One is that for the first year of the agreement, people who will be retained will be offered the same position at the same wage and the same benefit. Then after that, HCA's wages and benefits and so forth will kick in. From a board perspective, we've not asked about that. However, the transition plan is being now worked on by HCA's HR people and our HR people, but we don't know at this point what further changes will be made with regard to that. To step back, one of the analytics we did in considering whether to stay independent was 5 years out, what would we have to do about our own staff? And the data said that within 5 years we'd have to let go 800 to 1,300 more people. The likelihood that the likelihood is that mainly that HCA will let go much fewer than that, and they will all be in back office functions being revenue cycle, IT, and supply chain.
And we do have a fund that we will retain after the sale, which is significant, that will help people with job placement, retraining if they should lose their jobs. But HCA has a lot of opportunities to be placed within their system because they are so big and have so many facilities. So we're hoping that that is minimal. But we certainly understand your concerns because we want to make sure that we don't, leave our employees that perhaps don't have a job moving forward after the first year, that we will help them secure another position in the community.
Follow up with that, is there something in the language or meetings that gave you the impression that you had to create this fund for employees after the first year? What led up to creating that?
The board created a fund of $30 million to be able to support employees in transition. And there's that's available for employees for job placement, for education, for transfers, for that sort of thing. In addition, as Janice points out, HCA has almost 300,000 employees throughout the country and about 10,000 open positions at any time. Many of those can be done from home. Revenue cycle and supply chain particularly can be done from home, IT as well. So we're hopeful that, that our employees here who may lose their positions will have the opportunity to apply to HCA, will rise to the top of the list at HCA, and then could possibly be able to work from here. So, in any transaction like this, some people will lose their jobs. We're trying to do the best we can to minimize that and to maximize the chance that they have in transferring to HCA jobs.
So I think when we get an audience with HCA, that same question about wages, I think, will come up. And now normally our wages here are a lot less than other places, so we maybe shouldn't be worried about that. But I think we still would want to ask that question about what happens after year one.
And let's remember that HCA is still in the healthcare business. They still want to run a high quality, top-notch hospital. So some of these wages are market driven. If they lose their employees, they are in the same situation as others in the community that can't hire people. So I think from that perspective, their wages, I can't say this for sure, but I think they will be very competitive. I would not think that they would be appreciably lower or,
Yeah. Right. You answered one of my other questions, which was about, sort of outsourcing of jobs or the jobs that might be lost because of the merger. So I hear you on that. I would be curious to know, again, sort of either percentage or estimated number, just so we have a sense of that. Are we talking about 50 people? Are we talking about 300 people? And again, you may not know that, but that would be a question for them.
We don't know that now. The two HR departments are beginning to work together on a transition plan.
Right.
But part of the uncertainty is that we may not be able to consummate the transaction. If we don't, then we've got some catch up to do.
Sure. And then my last question on this is, I know that Mission contracts with certain medical groups, like for ER and pulmonary and some other things. And again, do you know what HCA's intention is around those groups in particular, and whether they would be looking, or are there provisions in the contract for renewing those contracts at sort of the same level for some period of time, or what's the provision for those groups?
Those contracts will be renewed. And in fact, the people who are now are most positive about the transaction and the advisors, particularly those groups, because they saw clinical cuts coming if we were in.
So, can you clarify something for me? You talked about the charity policy, that they agreed to maintain the same charity level as the highest healthcare system in the state, but yet,
yes.
But then you also said that Mission's charity is the highest in the state already. 72%. So I guess I'm just trying to reconcile. So
clarify that.
Thank you.
72% of Mission's patients are covered by Medicare, Medicaid, or self-pay. The charity policy is particularly related to those who are self-pay. And our charity policy goes up to 200% of poverty. Theirs already, HCA's across the board, is better than that.
Okay.
They will keep their policy, so it would be better than ours now. But the worst it would be is the best of the nonprofit systems in the state. So that's the floor. But theirs is better now, but that a floor is built into the contract.
Okay.
If they should change their policy, you know, if they should, you know, change the requirements, it has to match that. The largest nonprofit in the state.
Okay, that helps, thank you.
The question, oh, go ahead, Mr. Whiteside. Okay.
You go ahead, I'll be after you.
So, and we talked about this a little bit, this kind of question the last time I think we got together, and just sort of thinking about it a bit further. The, you know, I think one of the things that folks in the community, when they think about this, you know, this transition, it's all moves forward, is just sort of how the business model works in terms of how it will be more successful under HCA, the whole system that HCA has, as opposed to Mission as a standalone organization. You know, when we hear about, well, you know, it has a lot to do with just the economy of scales of their organization and the efficiencies that go along with that. And, but, you know, when people think of it, you know, when I hear people ask me about this, it's like, is this going to be a good thing? And, you know, understanding that the HCA is going to have to, of course, pay to acquire the system, you know, 1.5 million, pay all these property taxes, which we like that, right? Billion, did I say million?
Yeah.
Okay, billion. I did know that. $1 million.
That'd be a really good deal.
So, you know, I think people want to understand, you know, are the efficiencies of the system under HCA, that's the future, how are they greater than, you know, having to pay all the property taxes, of course having to make this big payment to just acquire the system? Are those efficiencies clearly outweighing the things that in some ways are kind of advantageous to the way Mission operates today? And I'm just curious, as part of the due diligence the board has done and the staff have done, kind of how deep of a dive you've taken to look at that? Because obviously if that's all true, then it's, you know, it could just be a better model going forward. If it's not true, then, you know, of course there would be this concern about maybe it runs for 10 years, but then it hits, you know, maybe if that isn't true and the drags on that model aren't outweighed by the efficiencies, maybe it's not such a good long-term solution. But I'm just kind of curious to hear any additional thoughts around how much of a detailed dive in that, the finances of that has been taken to kind of get comfortable that that really is going to play out that way.
A couple of examples. The average hospital in the country, average non-profit hospital in the country, loses about 9.5 cents on the dollar for every Medicare patient. Mission a couple of years ago lost 4. We're losing about 6 cents on the dollar. 2 years ago, HCA made 2.5 cents on the dollar and is breaking even now. So there's a 10 cents there is a measure of their efficiency. Second example, when you may have recalled a couple of years ago, we made an arrangement with GE for innovation here at the hospital. Part of what we wanted from them is to be able to buy from them at a cheaper rate. And we suggested that they give us the cheapest rate that they give any other group. And they said, not a chance. HCA has that one. Mm-hmm. So that 2 examples that they buy because they can buy volume. One of the things that they do is, as you know, drug prices are spiking up and down and up and down and up and down. They can buy volume at the lowest level when that's available on the spot market and store that so that they don't have to pay the kind of cost that we have to pay on drugs. So supply chain is the main place, but also then IT and revenue cycle. We've got to have a lot of people in billing because there are hundreds of insurance companies that people have that come to us, and we've got to be working with those individually. What HCA can do in 4 regional centers is almost covers all of their revenue cycle things, where we have to have a lot of people to be able to do it. Could never get to the kind of scale that they had. So the board did a deep dive in the 3 areas where we know that they can save money, which is revenue cycle, IT, and HR. In addition, we looked at their clinical staffing patterns and how they went about that. Their staffing patterns are, in some cases, better than ours, in all cases, the same as ours, as far as numbers of nurses per case per unit. And so, you know, we looked at, they're not cutting in the clinical side, which is what matters to patients and which matters to us. They're cutting in the places where they can be more efficient
Thank you. That's helpful.
Yeah, thanks. First of all, I think I need to give full disclosure here because I have several good friends in the AG's office, and one reached out to me yesterday, and I talked to him for about an hour, and I'm going to share with you the concerns I shared with him. And I have two. One is, from what I read on HCA, it was obvious to me, and you pointed that out, that they have built a franchise a lot on failed hospitals. You know, they've gone in and they've rescued them. The other is that we're the first, correct me if I'm wrong, we're the first hospital system they will be purchasing, right?
No, they've purchased others.
Yeah.
Have they?
Oh, yeah, that's how they. Yeah,
But
they just
hospital
purchased-
systems who were making money?
No,
Oh, no.
no, ours was first.
Okay, that's what I mean. We're the first that they're purchased who, have been successful. Well, we, have not seen eyeball to eyeball with one person from HCA. And I think that's very important because when you look, and from what I hear from talking to people in the community, we don't have enough information, and they are concerned because we have a well-run hospital, and we still have got to make sure that the people in our footprint understand why we're selling Mission or merging with the HCA, because they don't understand that. And especially when you get away from Asheville, I hear it, if you're in Marion or if you're in Franklin or the other areas. And I have friends out there because when I was working, I worked from Boone to Murphy, so I still talk to a lot of them. But that's one concern, is the PR, that are you doing it right? And when I worked on mergers and banking, we made a point to get out there and do as much as we can when we were in Florida, Pennsylvania, Virginia, when First Union was spreading out. But that's a concern. And the other I have is with the foundation, we're going to have, and I mentioned this to you, Janice, I think, we're going to have $1.5 billion or more in this foundation. I'm concerned that the people who that foundation will be taken care of, I want to see them represented. And from what I see at the board now, of the board of the foundation, when I look at diversity and just geographically, I don't feel that the 18-county area is being represented the way it should be if we're going to take care of all the people in these areas. Sure, Buncombe County and Asheville will be fine, but what about the outlying areas?
I'll be happy to answer that. Okay.
Yeah.
I'll let her answer the second question, and I'll come back to the
Okay,
first.
yeah, right.
Yeah, about the HCA, I'm sorry. Let me answer the second question. We understand what challenges we have with the board now, and we don't think that they're as great as other people perceive. We are going to look for more regional representation and diversity, both in gender and racial diversity, and we're looking for those folks right now. Where the rubber will be meeting the road for the Health Trust will be our partnerships through our staff with nonprofits, with local leaders, and all of that will actually be doing the work. And we anticipate having committees that will speak to these issues and have representatives that are experts in those areas, maybe opioid, opioid crisis representatives, housing representatives, food insecurity representatives. So we will have those people at the table. And we certainly, the thing that we had to do starting up was a lot of our work going forward is governance and just setting up the foundation. And we needed some people who had that expertise. And a lot of these people that are on the board have regional connections. They know people out in the region, their territories reach out in the region. So we feel like we're getting a good representation. And if you could meet with some of those board members, you would find their passion is intact and is truly will address exactly what you're talking about. So, we hope to show you more through our board selection in the next probably 2 to 3 months.
Let me ask Rowena to answer the question having to do with the HCA vote, but then let me answer the substance of the question.
Yeah.
Thank you. So we are working with HCA now, coordinating schedules and calendars and some other things we do. As you know, we do some legislative roundtables every quarter. They'll be joining us for our next legislative roundtable. We're working with dates now. So yes, they will be with us the end of November, beginning of December in some cases, because we have so many that we do at one time. And as you can imagine, and you may not know this, but they've just been through 2 tremendous hurricanes within their system. They just went through Michael, and just prior to that, the other. Florence. What is it?
Not Florence, but Harvey.
Harvey. That's right, yeah. So yes, well, they just went through 2, the one in South Carolina and the one that they just went through in the Panhandle, where they had hospitals significantly impacted, significantly. So what happens when that happens, they are incredibly great at that work. But basically, the gentleman that runs our division will oversee this transaction, has been on site in those places, moving people out of hospitals and moving them to safe locations. So they've been really focused on that, which meant we had to move a couple of these meetings out a little further than we had hoped. But I hear you, we hear you, they hear you. I have brought this back, as has Dr. Paulus, as has the board chair, saying we need to get you in. And clearly, to get them in before the clock has even started ticking is a bit premature too. So we're trying to walk a fine line of what makes the most sense for their timing, our timing, the AG's timing, and clearly the community's timing.
I thought the clock started ticking a year ago when you started talking to them.
No.
Okay.
I guess
Let me
Thank you.
answer.
Thank you.
Okay, yeah.
The rest of the question come to you, if that's okay. I hope our briefing has helped you understand a little bit more about why we made the decision. But
I was on the foundation board for 12 years and went on. I understand why you're making the decision. Yes.
We could have waited. And if we waited, we would have lost 2 really major things. One is we would have lost the foundation. That is, we wouldn't have gotten the kind of purchase price we're getting now if we'd waited 5 years, if we'd waited 10. But the other piece is we would have no negotiating capability to get the kind of guarantees, both for Mission and for the regional hospitals that we have now. HCA has never given those guarantees. So the leverage we had doing the deal now was so much greater than the leverage we would have had in 5 years.
Yeah, I guess to reiterate what everyone has said, the community, hospital employees would feel much better if they had more of a concept or an idea what this was going to be like. When you Google HCA layoffs, when you Google the CEO makes 312 times more than the median employee in 2017, where the median average wage is $55,000 a year. Those are all things without meeting face to face. And, as Al said, this has been going on for a really long time. And to be a good neighbor, to be someone, that the community wants to welcome, it would have been tremendous goodwill to come to the community at least once. And I understand about the hurricanes, but this has been going on for a long time. And so the longer it goes on, people that work at the hospital are getting more and more nervous. They're aware of different structures. And I think had someone come to reassure them, but maybe they don't want to reassure them. Maybe, if you all have set up a contingency plan to help displaced workers, that just all leads to the fear. So, I think initially we had good thoughts about all this, but the longer it drags on without ever, BJ has certainly asked many times if someone could come, it's not just us, it's our community in the Western region that fears would be assuaged.
I'd like to add to that. Over the last month, 45 days? Over the last 45 days, leaders from HCA have been in the hospital, hundreds of them. hundreds of them meeting with staff, they're taking back ideas. They've said many times, wow, in any particular division we might talk about, wow, you guys are doing some great work here. We'd like to take that back to the HCA family. So they have been in the hospital, in all of our hospitals, and looking at the facilities and talking to our team leaders and discussing, hey, how do you do it? And so it has not been, you're not seeing it, you don't have a line of sight to that, but hundreds of HCA folks have been in talking with our teams.
I guess if they can do that, then why couldn't they meet with community leaders?
They plan to, absolutely plan to.
Yeah, one example of what they're doing with the staff in the hospital was that when they came in to talk to the revenue cycle people, they realized that our computer programs were one generation better than theirs, and so they would keep more of the revenue staff rather than let them go. Same occurred in IT as well, that we were one generation beyond them. Instead of what they would normally do in a distressed hospital, which is come in and make their changeover on day one, they're not going to make it on day one. So one of the reasons there's uncertainty with the staff is because they may have expected, well, I'm going to lose my job, and now it looks like they may keep it because of the way in which in the last 45 days HCA has come in and found that we're better than they in certain things.
One of the really remarkable things I think about Mission and their system has been the leadership that they've demonstrated with respect to our safety net, the collaboration with MAHEC, and with and then we have others that I'm not quite sure about, the FQACs and CCWNC, and of course VIA. And I know, I remember the white paper that was developed with MAHEC and VIA, it wasn't called VIA then, in response to Medicaid reform, for example. So Mission has been an integral part of the safety net in Western North Carolina. And so reading the, not the contract, but the
APA?
Thank you. There was some verbiage in there about residency programs, maybe about the FQACs getting into that kind of business. How do we protect those safety net organizations that so many of our folks depend on?
Yeah, I'll take the residency part and part of the MAHEC part, and Innocent Rolling can take the other part. Mission just signed a renewal contract with MAHEC for 5 years. Normally we've been on a 3-year rolling thing, it's a 5-year thing. So that's set, and the contract flows over to HCA, they must honor that contract. MAHEC is awfully important. Second of all, HCA, because of the number of hospitals it's had that are teaching hospitals, actually trains more residents than any other system in the country. And part of the APA, the Asset Purchase Agreement, are guarantees to continue that and even to expand in certain areas for residency programs at Mission with MAHEC. So I don't know if you want to talk about the
Sure. Okay, I will talk about, you're talking about safety net organizations and community and Mission's community benefits program. So, Mission is very generous with those programs, and there are some guarantees that going forward into 2019 that will continue funding some of those safety net organizations. At that point, at the point that we go out into our listening sessions, one of the first things we will do is we will work with all of the organizations that have benefited from mission support, particularly those organizations that are not-for-profit that have been doing critical work out there. So we intend on developing partnerships with them going forward from the Dogwood Health Trust to ensure that that their funding is not devastated. And so that's a big part of our listening sessions that we're going to be having. We have a list of those partners. We will continue to look at those and see how we can and support them going forward. The big thing about the Dogwood Health Trust is what we want to do is we want to intervene before they ever need that safety net. We want to create opportunities for people to be well and to live up to their potential in Western North Carolina. So whether that be food insecurity or opioid crisis or housing or transportation, all of those things that prevent people from being well in the first place, we're gonna try to create a safety net for them prior to them needing resources. So we're gonna work on all of that. So we think we have a plan. We just need to get some meat on the bones of the plan.
So I got just a couple of things. One is I've been fortunate to be able to come to a few meetings and be updated by Mr. Paulus and yourself, and the last one was extremely helpful. We had some confusion among the commissioners, and I was able to get. I know Mr. Whiteside was hung up, and he was trying to get there. But it was very helpful to me. From explaining, as the chairman was talking about the efficiencies of HCA, we went into a lot of detail, and I was for one very, very excited about the possibility of them being able to deliver more affordable health care in the mission that Mission Health has been trying to do and doing well for years. I have been part of a major acquisition. When I was with, and I'll very briefly say, when I was with Clayton Homes, Berkshire Hathaway bought us out. Warren Buffett. I'd been with the company for 25 years and was one of at the time it occurred, was a VP. When I first heard the news, it was a gut punch to me because I'd been with them forever. This was my company. I had my trust level was zero. I didn't know Warren Buffett I just didn't know who he was.
From Jimmy Buffett.
I didn't know Warren Buffett from Jimmy. Knew more about Jimmy Buffett than I did Warren Buffett. Yes, I did.
Now that would be fun.
That would have been, yeah.
Total trust.
That would have been cool. But, so there was a lot of concern. 6,000 employees. But we were in a market that was against manufactured housing from a lending standpoint. We were doing very well as a lender, but everybody else was terrible. The stock market was brutal. We were having to react and make determinations based on all those external things. What happened was when Berkshire Hathaway come and bought the company, all the fears we had never come to fruition because of the efficiencies, because it took us out of all the political mess, out of the mess within the stock market. The company flourished. They were able to make good decisions instead of making so many decisions that were based on external things. So the information I've received about HCA, about their efficiencies, I've received it very positively. To me, the guarantees you're making for team members is proactive. It's not, though I think it comes from a genuine concern and from a very good, personal position that we definitely should be concerned about the wages. We should be concerned about, those people having a job. I don't think you're not concerned about that. I think you're taking proactive steps to make sure that is done. As far as the foundation is an elected official, the most exciting part for me, a lot of people got giddy over the property taxes. I didn't get as giddy as everybody else, but that does take pressure off of our local taxpayers, and that's a very positive thing. But the foundation, I think about our 6 priorities that the commission has. And I would think that many of those are going to line up with the foundation, and therefore we're going to be ones that I hope is going to be coming and asking the foundation to help take even more pressure off of taxpayers in Buncombe County by receiving some of those benefits and being a partner with you. I do share, not necessarily concerned about who's on the board, but about having information about the board. I think that just is to Commissioner Whiteside's point. I think it's very good that we would know who those are, that we might be able to, just work together and study that a little bit more. And I also don't think it's a bad idea for us to be able to, for some HCA people to come and, and answer questions, firsthand. At the same time, this is a big deal, and I think there are things within the process that slow it down. I'm not necessarily interested in being one of those that slows it down. I think there are things within the system that will do that because it has to go through the AG, it has to do some other things. So, but I do hear some concerns out in the community, but also hear a tremendous amount, a lot of excitement from people that's going to be able. I mean, my understanding, I'm trying to think of tell me a very expensive piece of equipment that you have to buy. Laser knife? I mean, I don't know what that's called, but
MRI machine.
An MRI machine. My understanding is that Mission pays this amount here, and HCA pays somewhere down here. I mean, just an incredible difference in that. And to me, that's where the savings comes from, not from I think we should be concerned about the wages, but they would be foolish as a corporation to come in and cut people's pay. Because that goes through the system like wildfire, and you lose quality people, and you never get another acquisition. If they're very good at all, then that would be, from a leadership standpoint, foolish on their part. But it should be verified, as people talk about. It's a concern, and we need to put that message out there. But I was just blown away by the information I received about the efficiencies and about how they were able to actually make money on the Medicare and Medicaid, and that translates into breaking even or making 4 cents translates into many millions.
Just to put a point on something that Joe said about the foundation, I'm really glad to hear that you all are about to embark on a set of community conversations and conversations with local governments. I know the city looks forward with great relish to informing whoever's going to be part of that, hopefully some of the board members, about the work that and the investments that the city already has on that range of issues that we're now framing as social determinants of health. Obviously, the county has a whole different set of investments that they make. But I agree with Joe. I think there's an enormous opportunity here to help this community make incredible gains, and frankly, I think you're going to have a hard time moving away $50 to $75 million a year, at least initially. Well, and there, just so you know, there are opportunities that are ripe and ready.
Well, we know that at first we'll have a little problem getting dispersing that amount of money, but the whole purpose is to do it well, to do it with accountability, and to get results that we want. So we would err on the side of caution rather than just throwing money out into the community willy-nilly. And so the other thing is it has to cover the 18 counties. So that makes it a little difference. That that 50 to 75 million cannot go all the way. Cannot all go to Buncombe County. But we know that we are the center of the population mass, and we perhaps might have more more need in our community. But we need to have those sessions. They're being scheduled as we speak. I will tell you, our first session is up in Spruce Pine and Burnsville area. We have had some, pushback from the search group, and we want to maybe alleviate some of their concerns. So that's our first one, but we will be getting these on the calendar now. So.
And what I think the big hurdle here for Mission is your success. We're used to quality health care. Heck, I wouldn't be here today if it wasn't for Mission, but all of us, we're used to that. And that's where it becomes uncomfortable. We said, wait, what are you doing to us? And that's where I think the people need to feel comfortable, with that. We need to get that across too. because I think that's it. You know, sometimes your success is your ending, and I think in this case, that's where with PR we're running into it, just the success of mission.
And one thing that gives us optimism is that, as I previously said, HCA's business plan was to rescue the distressed hospitals. This is the first time that they've gone for a system that is really successful and really high quality.
I think it's great.
Why did they do that? A couple of reasons. One is the geographic reason. They have no hospitals in North Carolina among all of the Southeast, and that's where their normal thing is. So they would like to expand in North Carolina. The second and more important piece is with the coming sense that there will be consolidation across the country in the health system over the next 10 to 20 years, perhaps leading to only 10 or 15 systems. They've taken the first leap of buying a successful system, and that gives them a platform in the market that is unlike any other for-profit platform in the market. They can't blow this one and keep that platform. Mm-hmm. So that's something that really gives us optimism. It's in their best interest not to blow this thing.
That's exactly.
And what surprised me is when I found out that as big as they are, they only control 7% of the market. And that was surprising.
And that's the most, they're the biggest, the largest in the healthcare system. They only have 6 to 7% of the market.
Yeah.
I think the other thing too, the last thing that they're going to want to do in a market that has 3%, 3.5% unemployment is to spend time trying to recruit anybody.
Exactly.
I mean, the biggest deterrent that we have right now to worry about whether, I mean, I would assume you always worry about some top level positions. They get moved around and shuffled, but they probably get offers within the HCA system. But on the levels where we really have heartburn, which is entry level positions, in a market where the unemployment's so low, they are not going to move out any of those people. That would be foolishness.
So I have a question. Mr. Kapoor mentioned some of the concerns about the language and the ability to make changes to the APA as far as what hospitals might close down the road within the 10-year period. What leverage would the trust have, since you mentioned you're going to be the gatekeeper or to make sure that there's enforcement?
We have the ability to take them to arbitration once they have extended all of the guarantees. As John mentioned, whether their volume dropped 30%, whether the physicians that offer those services somehow left the community, so we didn't have the ability. The health trust can take them to arbitration. We can sue them. We can even buy back some of the services and operate them through the trust, through funding through the trust. So there are a number of contractual things that we will be able to do. But the first and foremost would probably be take them to arbitration.
Excuse me, Frank, all that's clearly indicated and spoken to in depth on missionforward.org, the specific questions.
Well, the search group had mentioned, they had told me that they felt that the hospital had given up its right to sue. Is that true or not?
I think that we would go through arbitration before we would sue.
That's also addressed on the site, Frank.
Yeah.
I would encourage you to go there for that kind of information.
I think that's the more virtuous path. But we don't anticipate that they don't have any reason to do things that would be detrimental to our rural system or to our local, with our new tower and all of that. They are good operators. They're good healthcare providers, and so they have some qualities that mirror missions as far as their healthcare delivery. So we will have a subset of the foundation that will be doing that work. We will probably hire a contract with someone who actually audits their behavior. And so we'll get those reports.
And what's the total number of people on the board? The trust.
The trust. Our bylaws say that we can have up to 15. Right now we have 9. So that's the reason we're looking for more board members. And and we want them to have those same types of attributes that our current board has, only more regionally diverse and more racially and gender diverse.
Have you heard from the NAACP?
Yes, we have. Yes,
What's their concern?
I'm meeting with, well, believe it or not, their main concern was women. They said, 50% of us are women, and their main concern was that we had not represented women on the board. Well, because there were 2 women and 7 men. So we're going to be looking for women to fulfill that, but we are going to meet with them. We're going to have a very honest and open conversation. We want to hear what they say, so I think that's next week that we will be meeting.
So we are about at time. So we're actually a little bit past time. So I just want to say thank you to everyone who was here. Just kind of last thought, I would want to just kind of underscore that if this transaction does go ahead and the Dogwood Trust is set up, obviously the investments it'll be able to make is one of the big benefits of this. The property tax benefits to local government, of course, significant, and we're going to be investing those into some of the same types of things. And I think we haven't made any decisions about what to do with that because it hasn't happened yet. We don't want to get ahead of that, but I think we want to invest those funds strategically as well. And so I think if this does all go ahead, I know I speak for everyone from the elected official standpoint and staff that we really look forward to having, good communication with the trust about how do we do this strategically. And some of these challenges, it will be a challenge to spend that much money, but the challenges out there in our community are very significant too. And so I know we want to look for ways to partner on those and create platforms to really look for sort of scalable solutions to some of these challenges that really affect our people in Buncombe County and Western North Carolina. So
we're on the same page. Thank you.
All right.
We're on the same page.
All right. Well, thank you all for being here.
Yeah,
I think
thanks,
we're done with
guys.
the meeting. Thanks to the city council for being here too.
Yeah, thanks.